Picture a guy named Dave. 52 years old, project manager, never misses a deadline at work but has not seen a doctor in 4 years. His dad had prostate cancer. His brother mentioned it once at Christmas dinner, and Dave changed the subject. Not because he did not care. Because somewhere in the back of his mind he had decided he was probably fine. No symptoms, not old enough to worry, and frankly a little scared of what a positive result might mean for his life. Dave is not unusual. And the myths he believed are exactly what we are busting today. Before we get into the myths, let me give you a quick picture of what we are actually dealing with here. Prostate cancer is the second most common cancer diagnosed in men in the United States. 1 in 5 men will be diagnosed with it at some point in their lifetime. That is not a rare disease. That is a common one. And yet the amount of misinformation floating around about it, the stuff that keeps men from getting screened or sends them into a panic when they do, is genuinely staggering. So let us clear it up properly, one myth at a time. Myth number 1. Prostate cancer is an old man's disease, and if you are in your 40s or early 50s, you do not need to think about it yet. This one feels logical on the surface because yes, the risk does go up with age and most diagnoses happen after 65. But here is where the logic falls apart. Most does not mean all. Prostate cancer can and does appear in men in their 40s and 50s. And for certain groups, the risk arrives earlier and harder than the average statistics suggest. Here is the part that matters most for this myth. Black men have more than a 70% higher incidence of prostate cancer than white men. Not slightly higher. 70%. And men with a strong family history, meaning more than one close relative diagnosed before age 65, are advised to start having screening conversations at age 40. Not 50. Not 60. 40. If your dad had it and your uncle had it, the idea that you are too young to think about this at 45 is not just wrong, it could genuinely cost you. Myth number 2. No symptoms means no cancer. This is probably the most dangerous myth on this list because it feels like common sense. If something was wrong, you would feel it. Right. That is how it works with a broken bone or a bad infection. But prostate cancer in its early stages is almost completely silent. No pain. No obvious urinary changes. Nothing that would send you to the doctor. Most early-stage prostate cancer is found through a blood test, not because a man walked in with alarming symptoms. Now, symptoms can appear. Trouble starting urination, a weak stream, needing to get up multiple times at night, blood in the urine, or bone pain in the hips and lower back if the cancer has already spread. But here is the critical thing to understand. Those symptoms are not specific to prostate cancer. A benign enlarged prostate, a prostate infection, or a urinary tract infection can cause most of those same symptoms. Waiting for dramatic warning signs before you talk to your doctor is like waiting for your engine to seize before you check the oil. By then, you are already in a harder situation. Myth number 3. A high PSA result means you definitely have cancer, and you will need a biopsy immediately. Most people get this completely wrong, so let me fix that. The PSA test measures a protein called prostate-specific antigen in your blood. It is produced by prostate cells, both healthy ones and cancerous ones. So an elevated reading is a signal that something is going on with your prostate. It is absolutely not a diagnosis of cancer. In fact, roughly 3 out of 4 men with a high PSA do not have clinically significant prostate cancer. Here is what actually raises PSA besides cancer. A benign enlarged prostate, which is extremely common in men over 50. Prostate inflammation or infection. A urinary tract infection. Recent sexual activity. Even vigorous exercise in some men. A urologist looking at your PSA result is not just looking at the number in isolation. They are looking at your age, how the number has trended over time, your prostate size, and your personal risk factors. There is no single PSA number that automatically means cancer. An elevated result means your prostate is asking for a closer look. That is all. And on the biopsy question, an elevated PSA does not automatically send you straight to a biopsy table. Your doctor might repeat the test first, check for infection, order imaging, and build a fuller picture of your risk before any decision is made about next steps. The process is measured and considered, not a panic sprint from blood test to procedure. Understanding that takes a huge amount of unnecessary fear off the table for men who are avoiding the test precisely because they are terrified of where it leads. Myth number 4. Prostate cancer is always aggressive and getting a diagnosis is essentially a death sentence. Let me paint you a picture. The overall 5-year survival rate for prostate cancer sits at around 98.6%. When it is caught early, before it has spread beyond the prostate, that 5-year survival rate is close to 100%. Roughly 9 out of 10 men diagnosed with prostate cancer survive it. This is not a disease you should be terrified to find. It is a disease you should be motivated to find early. Here is the nuance that most people miss. Prostate cancer is not one single thing. Some prostate cancers are slow-growing and low risk. They may never cause symptoms or threaten a man's life in his natural lifespan. Others are aggressive and need prompt treatment. The real question is not simply do you have prostate cancer. The real question is what kind do you have and how risky is it? That distinction matters more than you might think, because the answer shapes everything, from whether you need treatment immediately to whether you can simply be monitored. For men with low-grade, low-risk prostate cancer, active surveillance is now a mainstream and well-established option. That means regular PSA tests, physical exams, imaging, and sometimes repeat biopsies to monitor the cancer over time. No surgery. No radiation. Just careful, consistent watching. If the cancer shows signs of becoming more aggressive, you move to treatment. If it stays stable, you keep watching. This approach exists because treating every prostate cancer the same way would cause real harm without real benefit for many men. Myth number 5. Prostate cancer treatment always ruins your sex life and your bladder control permanently. This one keeps men away from treatment they genuinely need, and that makes it one of the most harmful myths on this list. The truth is that side effects on urinary control and sexual function are real. They are common. They are not a myth. But the word always is doing a lot of dishonest work in that sentence, because these effects are not universal, not always permanent, and often manageable. For bladder control, some men experience leakage or urgency after treatment. For some, this is temporary, lasting weeks to months as the body heals. For others it can be longer term. But there are real strategies to address it, including bladder training, pelvic floor exercises, medications, and in some cases additional procedures. For sexual function, modern surgical techniques are designed specifically to try to preserve the nerves involved in erections where it is medically safe to do so. Many men maintain or recover sexual function over time, though some will not return fully to their pre-treatment baseline. This is what your body is actually trying to tell you. If we catch this early, you have options. Options that include treatments designed to protect your quality of life, not just your survival. The trade-off between treating a dangerous cancer and accepting some risk of side effects is a deeply personal conversation, one you should be having with a specialist who knows your full picture. But refusing to engage with that conversation because you fear the worst-case outcome means you never get to hear about the best-case one. Before we wrap up, a quick word on 2 more misconceptions worth naming. First, if your father did not have prostate cancer, you are not automatically safe. Family history is one risk factor among several, and prostate cancer absolutely happens in men with no family history at all. Genetic syndromes like BRCA1 and BRCA2 mutations and Lynch syndrome can also raise your risk even if no male relative has ever been diagnosed. Second, the PSA test is not the enemy. For years the debate swung between screen everyone and screen no one, and a lot of men walked away thinking the test was not worth having. The current guidance is more measured. Talk to your doctor about your personal risk and decide together. Here is the part one wants you to take away from all of this. Every one of these myths does the same thing. They give men a reason to delay. Too young, no symptoms, scared of the result, scared of the treatment. And delay is exactly what prostate cancer benefits from. The 5-year survival rate when it is caught early and confined to the prostate is close to 100%. The conversation you keep putting off could be the one that keeps you around for the next 30 years. Dave, the guy I told you about at the start, eventually did go. His doctor had a proper conversation with him about his risk. That is all it took. If you are over 50 and at average risk, the guidance is to have a conversation with your doctor about PSA screening. If you are Black or have a close relative diagnosed before 65, that conversation should start at 45. If you have more than one first-degree relative diagnosed before 65 or a known family history of BRCA mutations or Lynch syndrome, the conversation starts at 40. Not a test necessarily. A conversation. That is the first step. You do not need to walk in with all the answers. You just need to walk in. If this video helped you feel a little more prepared to do that, then it did exactly what it was supposed to do.